very, not my favorite, most exciting P-SCIP meeting ever, but very, very important to the folks that this information speaks to. Um, so this is our P-SCIP measure specification and clinical consideration webinar. We're going to talk first about the measure specifications and any changes that have been made to those. And then we're going to talk about the clinical consideration process and any changes that have been made to that process. It's very, very important that if you have a question, please ask. You can raise your hand, you can interrupt me, you can put it in the chat box. Between Courtney and I, we will try to grab those questions. We have Tashara Cannon with us today from the state. So between the three of us, we should be able to answer the questions that you have. And if we can't answer the questions that you have, we will certainly find out and get back to you promptly. So just letting you all know that that's how this is kind of going to go. Nothing that is going to be presented today should be terribly shocking or surprising. It's really all about how do we continue to iterate as we learn together and go down this P-SCIP journey of almost 5 years in this collaborative. So thank you again for being here and for learning with us. And if you were one of the collaborators that helped with this, also thanks for that. And we'll talk about that in a minute. So our agenda, again, is going to be really, really focused and specific, and that is to talk about any sort of updates to the measure specifications and the code tables, talk a little bit about the process, and just highlight the implementation plan that measure specification changes are implemented as of now, June 2026, and that will go, you will see that in your December 2025 data poll that you'll see from Optum in Care Connect 360. And then we'll talk about the narrative template, specifically that clinical consideration process that you all worked on last year, and we have improved over time. So with that, let's talk a little bit about the updated measure specifications and the code tables. I want to just highlight the fact that at different points in time, you may be sent a measure specification that in the measure specification, there are code tables. Oh, I'm hearing myself twice. But then there are also Excel files with the code tables, and we'll talk a little bit about that as well. But you will get these in emails, and it's important to know that what version you're looking at as it relates to the current measurement year that you're working on improving your rates for preventive service delivery for children. And so with that said, the state provided a big email with a whole bunch of things back on March 18th, 2026. In that email, the measure specification that was included was indeed the current measure specification that was current at that time. However, simultaneously at the same time, we were actively in the process of updating the measure specification, which means that certain people saw maybe or were a part of a conversation about changes to the measure specification that were not reflected in that email. And I know that that's a little confusing, but we typically want to do a process like this where we work through updates and we collect feedback on updates. And then once those updates are ready, we deliver that to the collaborative. We deliver that to the plans that comes from the state, that comes from our P-SCIP group, via Courtney and her messaging that goes on the website, right? And so the version that was sent out in March does not include all of the updated NDC codes that the pharmacy work group had been already working on to include in this version of the measure specification. Yes, Tashara, you've got your hand raised.
Yeah, I just wanted to add on to what you're saying, Corey, about the specs they received in March. So that was a part of our non-PMR measure spec document that went out. So our plan is to send that particular spec document out every year. And so the hope, well, you will have the updated measure specs as we send them out every year at that moment in time. So you'll probably get these specs twice, once with that document, and then another, once again, once we send it with the template. So um, just wanted to add that in.
Yeah, thanks. And we're trying to make sure that they're all, dated up and watermarked up, and so that it's really clear that this is the version that y'all are working on without being too rigid and too specific, because I think that when we had some dates on the measure specification, it impacted how people were actually implementing that, and if some of those members were included or not included in the measurement year. So we'll look at that together, but I just wanted to give that caveat. So if we talk a little bit about process, just to be transparent to everyone in the group, the goal is to update the measure specification every year, that would be an annual update. And the reason why that's important is because we want to make sure that the measure specifications and the codes are accurate, vetted, and aligned across all of the stakeholders for implementation. Now, there are some things that do not require updates annually. ICD-10 codes do not require an annual update, but NCD codes are and DC codes, flip it around, are changing constantly. And so it does seem important to make sure that we're including updates on all of those codes every year. And so this is what that process looks like for transparency standpoint. So in January, starting kind of in January time period, our group engages with different subject matter experts on what are the updates that need to happen to the measure specifications. So the P-SCIP team, myself, Courtney, under Dr. Freed, through the support of Dr. Sarah Reeves, who actually was the one that created these measure specifications, we say, okay, we're the subject measure expert on the measures, but we got to talk to different folks to think about what are the right ICD-10 codes, what are the right CPT codes, what are the right NDC codes. And so we talked to a variety of people to say, have there been any changes? Do we need to make any changes? What does that look like? Then we go to the pharmacy work group, who is reviewing codes regularly, right? Especially those NDC codes regularly, to say, are you all seeing changes in codes? Is there an update that needs to happen? And so we ask for 3 different plans within the pharmacy work group to help us reconcile those codes by, looking into their own systems and taking our code tables and seeing what might be expired, and what we might need is new or revised that we need to add. So we collect that information from them, and then we do an initial identification for any sort of inclusions or required code lists that need to be updated. So this is like kind of the exploration phase that happens between January and March. And if you join our pharmacy work group call, that is something that we talk about and talk through in that call and ask for folks to help us with. Then in April, we have some internal reconciliation, and I say we, meaning back to Courtney and myself and Dr. Freed, where we're reconciling all of the additional additions and revisions and requests. Courtney is the hero in this space. She did the bulk of this work just recently, just like taking all of those codes from the providers, comparing that for duplicates in the lists, organizing those appropriately. It's a bit of a task, and so I'm deeply appreciative for Courtney for helping with that work. then we update the specifications and the code tables, and we're tracking that with watermarks and versions and highlighting anything that is new or updated on that. Again, this is not something that we have sent out to the public, to the plans yet. This is a working document that we're kind of revising on and making sure that we have all of the pieces and the parts correct. Then in May, we do what's called external vetting. It's not totally external. It's, you know, getting those measure specifications to MDHHS, getting them to TSHARA. TSHARA gets them over to Optum. There is a review process that happens. Optum compares the new codes with on the new specs versus the codes on the existing specs, helps us see if there's duplicates, helps us to see, you know, is everything passing the sniff check, and then provides us feedback for that. We incorporate the feedback into the measure specifications, and that final validation piece is complete. And those versions are then date stamped for implementation. When is the expected implementation date? That's something that we talk about and collaborate on, because we don't want to implement something that could set health plans up to not be successful in your efforts, right? So we have a lot of thought about, should we implement this now, or is this something that we should implement for the next kind of fiscal year, depending, or the measurement year, depending on what the change is. And then they're date stamped. They would be posted on our pediatric sickle cell website, and they would also be distributed to the state and to the plans for programming and implementation. Any questions on that process? Great. This year, and you'll see this in a moment, the only changes that we made to the measure specifications are the NDC codes. That's it. We did not do changes to ICD-10 codes. We did not do changes to CPT codes. The only changes are to the NDC codes. And the reason for that is that next year, our epidemiologist, Sarah Reeves, who created these measure specifications, is going to do a revalidation process of all three measure specifications, where she's going to go through all of the ICD-10 codes, all of the CPT codes, all of the NDC codes. So there's going to be a larger update for next year, and so this process will look a little bit different. And when we walk through that process, we'll be really transparent with you all on it and think about when are we implementing it and for what measurement year. But I just want you to know, when you're like, wait, why haven't we updated NDC or CPT codes and ICD-10 codes in 2 years? Know that that is the plan for our next fiscal year, is to update those. So with that also means that the TCD code, or the TCD measure specification, has no changes on it, but we'll get to that part. So for the antibiotic measure specification, again, I don't feel like you need to read through this screen. I just want to highlight a couple of things for you. So when you look at the measure specification, on the bottom, we have an effective implementation date, where this effective implementation date is June of 2026. And so that means that this is the most recent version. We did not want to put that date into the actual specification, because it creates some confusion for member inclusion and who's included in the measures and who's not included in the measures. So that's why the intake period begins July 1 and ends June 30th of the following year. That was feedback that we got from you all, that would be less confusing if we didn't have to have language around the measurement period and the dates on every single version. So the effective implementation date for the antibiotic measure specification is June of this month. You will see over here on the right, on the third page, on where table 1 says about the NDC codes. And in that file, it says see attached Excel file. Sometimes the specifications get sent out and the Excel file is not sent out with it. That Excel file has, I think, 8,000 or 9,000 antibiotic codes. We could not put it in the measure specification if we wanted to. And so there's a separate Excel file. If you go to the P-SCIP website, there's 2 radio buttons that you can choose. One, and Courtney, maybe you could throw that in the chat box for us. One is the measure specification and one is the Excel file. And you click on the Excel file and you can download it, and it has all of the codes in the Excel file. The NDC codes for antibiotics were updated as of June 2026. So we updated the antibiotic codes. However, this is where it gets a little confusing because you see that date, but then you see the date here in table 2, the ICD-10 codes have not been updated. The last update for the ICD-10 codes were June of 2024. So the antibiotic code tables updated, the ICD-10 codes not updated. Rebecca, you have a question.
Hi, good morning, Corey.
Hi, good morning.
Just some clarification on the statement at the bottom. It's only the NDC codes were made to only NDC code changes were made to the antibiotics measure specification. Is that measurement year, is that correct, or is that supposed to be 7/1/26 to 6/30/27?
No, that is this measurement year. This is including in this measurement year for that we're in right now that's about to end. And the reason why is because you might have a child that's had 300 days of an antibiotic that was not on the code table, and we want you to get credit for that kid. So adding NDC codes does not hurt the plan. It only helps the plan in making sure that you have the appropriate kids with the appropriate medications and the appropriate day supply. Does that help answer your question?
Yeah, it does. I just well, I guess because Optum pulls the data too. I was just thinking like internally from our own perspective, because we pull it as these claims are coming in. So I was just trying to see if there's, I'll have to work with our DS to see if there's a workaround to get all that reran.
Yeah, and then it'll continue, right? So June 30th, the measurement year's over. You're going to still use this measure specification because we're not going to update this measure specification again until next year. So this is changed for this measurement year, but then it will also be used for next measurement year as you continue to run and check for codes. And then next January, we'll go through the process again of saying, are there other NDC codes that you're seeing that kids are getting prescriptions for, and we're not, and they're not included in the measure specification, and they should be.
Got it. So basically this is kind of like a catch-up year. That's
correct. Yep. Michael, I don't know what GPI is. Can you help me know what that is?
Generic product identifier. So under each GPI would be every NDC.
Okay.
So a GPI 14, so there's like multiple levels of it. So GPI 14 is the maximum number of digits to identify. So that would include the strength, the capsule, that sort of thing, tablet, formulation, suspension, whatever. And under each GPI 14 would be every single NDC. So if a new manufacturer falls on or off, you'd still be able to capture it.
Amazing. I think that's a good, and I don't know what other health plans are using.
For the most part, that's what we all use.
Okay, great.
I'm sorry, Stephen, go ahead.
Well, I just want to make sure we're clear on that. I think when we first came up with these metrics, we did suggest pulling at a higher level in the hierarchy with, for example, GPI. But some plans, GPI is specific to the database that you pull from. So if you use First Data Bank, you're using GCNs, et cetera, and not using GPI. If you're using Medispan, I believe that's the GPI. So it is different depending on the plan and what database they use.
And I think that that's where that reconciliation process is really important, right? And the fact that we had 3 plans look at this and look at their own system and identify any sort of missing or changed codes. And Courtney, can you remind me the plans that helped with that effort? I think it was Meridian, Have Care
Priority,
Source, and
and
Priority. Yeah.
One thing I would mention, because I like what Mike's saying, though, it is a good idea if there's any discussion and room available for that to pull at a higher level instead of being at the NDC level. Because, for example, if we were to use, GPI like Mike is using, you don't have to then go look for new NDCs, because those new NDCs are automatically, they fall under the GPI. So as long as you have the GPI, then any new NDC will automatically be captured moving forward, as opposed to having these charts and our Excels and everything based on NDC. Then you do have to add them as they come up.
Okay. That's a great thing that we should look into, especially for the update that we'll start working again, and knowing that Dr. Reeves is going to be revalidating the measures for validity and feasibility, which means that there's going to be some changes in it. So I think Courtney and I will pick your brains more about that and talk to Dr. Reeves and Tashara and Optum to see what options there are for that piece. So thank you for that. Okay, so that's the measure specification. And then the code tables, this is just a screen grab of the code table that I pulled from the P-SCIP website. So again, just showing you all of the code tables and that it was updated on June of 2026. I think we need to, I'm just looking at this one, and this row is sticking out for me for a second because we were modifying the code tables to include leading zeros, and looks like I screen grabbed this one before we did that. So I just want to check that before we send it, because there was some formatting suggestions that came through around making sure that the leading zeros were present in that file. So we will do a quick check before we send that out to everyone. Great. And then I think, yeah, I just wanted to highlight the fact that updating the NDC list going from 8,558 codes to 8,746 codes, there was no change in any of our measures. So there's a lot of antibiotics out there, but it seems like the antibiotics that are used for sickle cell really are only leverage about 80 of the codes of the almost 9,000 codes that exist. And we constantly want to make sure that that file is up to date for you all. So on the happen chance that there's a different code that's caught. But just to note that including these codes did not change anything for the measure specifications. Yes, Rebecca.
Another question. So the codes that were added, is there an indicator that they're new?
Yes.
Are they in a, okay, cool, thanks.
Yep, they're highlighted in yellow.
Perfect.
You're welcome. Okay, you'll see that in the next slide or when we talk about hydroxyurea. So that was antibiotics. So now we're going to talk about hydroxyurea. Again, the hydroxyurea measure specification, you will see on the bottom, effective June of 2026. The language in the specification itself did not change. I want to highlight the fact that we are now implementing the spillage, what we call the spillage language around the medications. We talked about that last June. We said that it was going to start being implemented in July of 2025. It's now implemented. It has been implemented through July through now. And that language we're going to continue to use, and it is in the measure specification if you need to familiarize yourself with that. The effective date, June 2026. The code tables for hydroxyurea, we have an Excel version, but they also are in the measure specification. There are 92 unique codes for hydroxyurea. That was updated as of June 2026. We feel that we validated all of these things and the codes are included. And here is what the code table looks like in the Excel version. Again, you see the highlighted codes that were added. Updating the hydroxyurea NDC list resulted in a tiny bit of improvement to the measure from a statewide level. It increased the numerator from 67 kids getting that are eligible for 667 kids at 300 days supply of hydroxyurea to 71 kids at 300 days supply of hydroxyurea across the state. So a 1.33% point increase by including those codes. The updated code set, I already disclosed this, included 92 unique NDCs. So now we have new codes for hydroxyurea that we want you all to make sure that you're programming. Yes, X-Romy was included. That's that first highlighted code. Questions?
Hey, Courtney, Brian from Meridian here. Just one thing that's jumping out to me on that, like what you have highlighted and boxed in red there. It's kind of like a formatting and consistency concern, I guess, is that
The dashes.
the dashes, and then again, if there's leading zeros, want to make sure those are like present and formatted in the Excel file tables to make sure those don't get deleted.
Great. Yep, we'll do one more quality assurance check before it goes out to everyone, making sure that there's leading zeros and removing any of the dashes.
Okay, thank you.
Sound good?
Absolutely.
Thanks. And this is where we need your input, your feedback, your, poking through things. So I appreciate all of the help that it takes a village. So I appreciate all of the help and assistance in this space. Questions, comments about hydroxyurea? Terrific. Okay. As I mentioned, TCD, no updates. So CPT codes were not updated. ICD-10 codes were not updated. We looked at the measure specification for language, ensured that the language was consistent, signed off on it for the date of June 2026. But the way that you programmed it and the way that you have programmed it should be the same because there's no changes to this measure specification. So we can just move forward on that one. Now I want to get to the point. Oh, just some comments. So these measure specifications are being used for the December 2025 poll that you should be getting in you should see that in Care Connect 360 in a couple of weeks. I think around the 15th of June. And it will be fully implemented, which is now, and that will carry back to the full measurement year. So that will get programmed retrospectively to encompass the full measurement period. The expanded NDC list of codes increase the capture of dispensed medications and improve measure identification, including the codes are not going to hurt you, right? They're only going to help you make sure that we're casting the right net to make sure that the kids are getting the medications and that we have data on that. No updates were made to ICD-10 or CPT codes. And the revised measure specification will be distributed to the health plans by the end of the week and posted on the website. Before we do that, we're going to just do one last check to make sure that leading zeros are on all of the code tables and all of any sort of dashes or things that look a little funky are removed. So we'll do one last spot check of that, and we'll send that to Shara to send to Optum. We'll send that to the plans. It'll go on the website. Everyone will have it. And if there is something that needs to be changed, and some circumstance that there is something like you write me back and you say, oh, Corey, this one's messed up, it's not right. We'll make sure that we go back to the process of updating that, changing the date on the bottom of it so that it's clear that that date has been changed, highlighting what the change is, resending that out to all of the plans, re-updating that on the version on the website, and we'll put a little blurb on there as well that this is the change and this is why we changed it, so that we can maintain really clear communication and consistency on these things. Okay, so now let's talk about the narrative template updates and the clinical consideration process. This is going to be our third year doing the clinical consideration process. Last year, I think, was wildly successful in the fact that we had very, very, very few declines of clinical considerations. I think that there was only like 2. And the reason for that is the fact that you're all able to leverage Care Connect 360 to see who's in your denominator and who's in your numerator. And then in the template, you provided very, very clear documentation about why you think that this kiddo shouldn't be a part of your denominator. And that documentation was really, really instrumental in our ability to kind of walk through that and then verify that with the state and with Optum to then go ahead and improve those things or ask for additional information. And then, you know, you all kind of have this running log of any sort of clinical considerations that were approved that you will continue to just kind of monitor, right? And to know that those kiddos shouldn't be a part of your quality measures for the reasons. The 2 biggest reasons in the clinical consideration process last year were truly approved clinical consideration for a clinical reason, like chronic transfusion therapy for kids, or they, you know, had moya syndrome and it wasn't appropriate, right? And the fact that you all had documentation on these things, or it was a coding issue on the clinic side where you see that somebody has type SS, they're sickle cell anemia, they're in your denominator, and then you call the clinic and the clinic says, no, this kid actually has trait, right? Or they have SC. And that means that there's a coding issue on the clinic end. And we already know that that clinic is really busy and they don't have time to like fix their codes. And we're not going to ask them to do that because it's hard enough to get them to pick up the phone to ask, you know, a clinical issue. So we're going to just continue to say that that is the truth and we're going to move forward. And so those were the groups of folks that we saw in the clinical consideration process last year. Much more, I would say, reliable, much more accurate. The documentation was really clear. Y'all did a really fantastic job in that process, and it made our job a lot easier to go through and navigate those things. So for this measurement year, and Tashara is in charge of the template and providing the template, but I wanted to really think about how do we learn from the clinical consideration process last year and apply that to this year? And so as a reminder, you all requested a process to remove members from the denominator when a preventative service may not be appropriate to a member for a special clinical reason. And that we asked that you could make a request in conjunction with your template that is sent annually to the state. And that those requests for submitting to the state are due September 30th, 2026. And this will be Tashara's thing that she will speak to and provide context to. I want to just say that there are no assumed or automatic clinical considerations carried over from prior years. We don't want to assume anything. We want to create a process in which people are still laying eyes on things and making sure that you know, we're not forgetting about a kid or ignoring something or glazing over something. So nothing is assumed on the Optum Care Connect 360 end. However, not all resubmissions will require new documentations or review or approval from the clinical providers. If Dr. Glaros or Val said a TCD is not appropriate for a kid, or hydroxyurea is not appropriate for a kid, and we have documentation of that, then we don't need to ask them that again. Unless you see that something has changed in your claims, right? Like maybe all of a sudden that kid got a TCD and you had a clinical consideration that they didn't need a TCD, then I would ask you to, go and get a hold of the clinic and say, is it just because the kid came into the clinic and you did a TCD, or are they on a different path now? Are they off chronic transfusions? It doesn't happen often. So we don't want to create a system that creates burden on these clinics or on you all, but I'm going to ask you all to just review that and review your claims when you're looking through your lists. But the clinical considerations still must be resubmitted in the template. And there is a new table in the template that I'm going to show you in a moment that is previously approved exemptions for clinical considerations for resubmission. So what this looks like, actually, let's talk process first. So the process is for plans that are submitting a request, you're going to first look in Care Connect 360, and you're going to make sure that those kiddos are in your denominator. This is all the same as last year. If members are included in the denominator, you can submit a request for clinical consideration. For members with a previously approved exemption for clinical considerations for this new period, health plans may submit an abbreviated resubmission by indicating the previous approval justification and the relevant codes in the table. New supporting documentation is only required if their clinical circumstances have changed. MDHHS and the U of M team will confirm prior approval and determine whether re-review of the member is necessary. Then you're going to, if members are not included in the denominator, health plans do not need to request an exemption for those members. Health plans submit their narrative template to the state by September 30th. The state sends the information, the request information to the U of M team for us to review. We provide feedback to the state regarding any sort of additional requests. This typically looks like Tashara, Courtney, and I getting in a call. We look at everything together. We talk about it, right? Like nothing happens in a vacuum. We are really clear on what the request is and who needs to send it and what the information is. We might be pulling in Optum to say, hey, can you help us verify something? So this is something that happens very, very collaboratively. And then after there is sign off and approval and all of those things, we ask Optum to remove the approved members from your denominators. Optum removes the members from the denominators for the annual performance bonus. The members will also be removed from 3 subsequent quarterly data polls, and the process is repeated annually. So here we are in our annual kind of review of that process. Then the state delivers your final template scoring to the plans. And to note that members that are excluded from your denominator of the quality measures work should still be visible in Care Connect 360 to support any sort of data collection. It's just in a separate section of Care Connect 360. A request for exemption for each member must be submitted annually. So that's the process. We can go back and talk about the process if we want to, but I think what you're all really want to look at is what does this actually look like? So in the template, this is what you saw previously. We have changed this to say any new clinical considerations. This number should be pretty small because y'all did the bulk of the work last year, right? So you submitted your clinical considerations last year. You had 10 members that were exempt for, a true clinical reason like chronic transfusion therapy. You probably don't have another 10 kids that are new to your plan and that are also on chronic transfusion. It might be 1, it might be 2. So I do not hypothesize that this table is going to be huge or exhaustive. I think it's going to be pretty small. This is where if it's a new clinical consideration, we do want that physician APP indication for exclusion being as specific as possible, right? Where it, and I'll show the example, but the name of the person that verified this, and they don't require this service, and the date. And so, it says the Courtney spoke with Ebony, who conferred with Dr. Galeros, and the member has a history of X and, undergoes chronic transfusion therapy and does not require to have a TCD done, right? That's the type of documentation that helps us say, no question, this child does not need a TCD because of all of these things. That is the process that we did last year, and we'll continue to do that this year for any new requests. Now, for all of those kiddos that you got exemptions for last year, this is the previously, table 2, the previously approved exemptions table. So this table is where you go and you look at your template for last year, and you look at Care Connect 360, and you see all of those kiddos that you got an approval for, and you make sure that they're still in Care Connect 360. So you kind of need to reconcile both of those things. And you say, we're going to want to submit this again. And so then you go through the table and you include their member ID, that you're seeing them still in Care Connect 360. They wouldn't be in your denominator and numerator. They'd be in that exemption area. And what was the documentation for approval last year? So looking at your template last year and seeing there's language that says approved for clinical considerations, right? That was our language that we gave back to you. Does this clinical consideration still apply? Yes. There might be some relevant codes, there might not be, but I would still say, yes, they last had chronic transfusion therapy on X date with X codes, and you see that in the example above, and then the date of the most recent claim. I'm getting dry. Sorry. So in the example, yes, they're there. The approval said approved for chronic transfusions. Yes, the member has recent claims for chronic transfusion therapy. Here are the most recent codes for that procedure. And here's the date of the most recent claim. And then that gives us an expedited way to say, okay, they're resubmitting for approval. We're going to go ahead and approve that. That is the long and the short of how this is going to look in your template. Questions? Does this sound good to folks? Can I get some thumbs up if it feels like this process is clear and you know what your next steps are? See a couple thumbs. And if we need to help you, we can help you, but we're trying to make it as clear as possible. Okay. So next steps for this, revisit your tracking system, right? Look at your internal system, look at Care Connect 360 and who your exclusions are. And you're going to want to look at, do you have any new clinical considerations that you didn't have last year that you need to get approval for? That's going to take some time. We know that clinic is busy. We know that the providers are sometimes hard to reach. So those are the ones that are going to take some time to get approval for. Follow the process for new clinical considerations. If they're on your list from last year and you want to resubmit them for this year, then you're looking at the data internally. You don't have to necessarily reach out to the clinic, but you're looking at the data to make sure that they're still on that same path. If they're not on the same path, that's when you would need to follow up with the clinic. But you should be able to see a kid that's on chronic transfusions is still getting chronic transfusions. And you can determine who needs to, for resubmission. And then just to note that doing this as soon as possible helps everyone in the long run. Know that in August and September, that hematology clinic at Children's is really busy because they also do wild child visits. And so they're doing all of their back to school appointments, their sports physicals, their vaccines, all of those things. So that's a tricky time for the clinic. Avoid asking for several clinical considerations, like don't send them a list of things. But again, I don't think you're going to need to send them a list of things because we already did that, right? So you already have your list. And just know that that turnaround time may not be quick. And we just want to be really respectful of the clinic staff and the fact that this is a bit of a data verification reconciliation process, and their priority is obviously the clinical care that